The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/VTT860. Downloadable slides and practice aids are also available.
Hello, my name is Bruce Cree. Welcome to Realizing the Full Clinical Potential of Sphingosine 1-Phosphate Receptor Modulation to Improve Outcomes in Patients with Multiple Sclerosis. I'm joined today by my colleague, Dr. Amit Bar-Or. So welcome. My name is Bruce Cree. I'm a professor of neurology at the University of California, San Francisco. When we think about disease courses in multiple sclerosis, we think about patients who have relapsing disease and whether they have active or inactive disease. We define disease activity by the presence of new and lesions on brain MRI or the occurrence of clinical relapses. With respect to progressive disease, the hallmark here is worsening of disability independent of relapses. And this can occur in patients who have primary progressive MS, who have no prior history of relapse but are worsening from disease onset, or in patients who have secondary progressive disease and have a prior history of relapses but are worsening now without relapses. And both these forms of progressive MS can be classified into active versus non-active states and with or without progression. Some of our goals of treatment with disease-modifying therapy are to reduce the incidence and severity of relapses, to decrease radiographic measures of disease activity, and to slow or prevent disability progression. We also are now thinking about methods to delay loss of brain tissue and possibly even spinal cord tissue, and thinking about how an impact on end organ damage may ultimately be of benefit to our treatments to our patients over the long term. So patients do need access to a range of disease-modifying therapies. Different disease phenotypes have approval for different disease-modifying therapies. Different mechanisms of action allow for treatment change if a response to one type of treatment is suboptimal. And there are limitations posed by various treatments and contraindications for pregnancy and breastfeeding. Risk tolerance is different for patients and clinicians, and DMT effects on adherence and quality of life have to be taken into account with respect to route of administration, dosing frequency, and side effects. The MS treatment landscape has evolved dramatically since the introduction of the first disease-modifying therapy in 1993, which was interferon beta-1b. We then saw evolution of additional self-injected medications in 1996, and then use of high-potency chemotherapeutic medication, mitoxantrone, and development of natalizumab in the 2000s. In around 2010, we began to see emergence of oral treatment options, which included fingolimod, dimethyl fumarate, and teriflunomide, as well as additional high-potency options such as alemtuzumab and ocrelizumab, as well as the first treatment that was investigated and found to be effective in secondary progressive MS, siponimod. We also saw a return of cladribine, and more recently we've seen further development with an additional oral treatment option, including ozanimod and monomethyl fumarate or diroximel fumarate, and most recently ofatumumab, a subcutaneous anti-CD20 monoclonal antibody. And in the near future, we're going to see further development of additional disease-modifying therapies for relapsing and hopefully progressive forms of multiple sclerosis. Multiple sphingosine 1-phosphate receptor modulators have been developed for treatment in multiple sclerosis. 3 of these have been approved and include fingolimod, siponimod, and ozanimod. 2 are still in clinical development, including ponesimod and amiselimod. So when we think about these drugs, even though they're chemically quite different based on their structure, they do have some advantages for our patients because they are immunomodulators. They do have a once-daily oral dosing. They can be highly effective at suppressing new lesion activity and suppressing relapses. And some of these have gone through at least one generation of development. And so we have more treatment options with respect to this class of therapies. And so questions that we have are, should these drugs be used frontline, second line, third line, or should their use be restricted to certain disease phenotypes? So I'm going to turn things over to my colleague and good friend, Professor Bar-Or from University of Pennsylvania, who's going to now speak to us about understanding the role of S1P and its receptors in the pathophysiology of MS and its implications for patient care. Professor Bar-Or.
Many thanks, Bruce, and hello, everybody. It's nice to be part of this program. What I'll do in the next few minutes is briefly talk a little bit about the role of sphingosine-1 phosphate, the ligand, and its receptors in a variety of biological processes, particularly in relation to those relevant to multiple sclerosis. We'll talk about the rationale for use in different forms of MS, and we'll discuss the approved and emerging S1P receptor modulators, in particular fingolimod, siponimod, ozanimod, and ponesimod, with respect to differences in their S1P receptor specificity and some implications for off-target effects. We'll talk about the pharmacokinetic and pharmacodynamic profiles briefly, and then comment on efficacy, safety, and tolerability, and draw some relationships to the receptor specificity and the PK/PD discussion. And then some practical aspects of its use will wrap up this brief presentation. And so to start with, what you see here is the typical bilayer of cells, and the circles representing one of the major building blocks, which is sphingomyelin. And at the bottom, below the membrane, you'll see the sequence in terms of the metabolic pathway of sphingomyelin through ceramide and sphingosine, eventually to this little molecule called sphingosine-1 phosphate, or S1P, which is then extruded from the cells and can participate through binding to a variety of receptors on other cells in a range of biological processes. And from the standpoint of relevance to multiple sclerosis, this table identifies the localization as well as the function of the different S1P receptors, shown on the left-hand side, the 5 receptor types S1P1 through S1P5 present in humans. And then across the top, you'll see the different major organs that we've considered in the context of MS, the CNS on the far left and the immune system on the far right, and then some questions related to potential off-target effects in the context of cardiovascular system and endothelial barriers. And a point to make on this is that the multiple receptors are present within the central nervous system on a variety of brain cells. The immune system, again on the far right, most of the effects of interest to us relate to the biology of the S1P binding to the S1P1 receptor, and relatively little expression of S1P4, with S1P3 thought to be the one particularly relevant to the cardiovascular effects and the aspects of conduction and heart rate that have been seen and monitored closely through the trials and post-marketing. This is a little cartoon schematic of a lymph node in the center with a circulation looking at lymphocytes from the left entering a secondary lymphoid organ. So that is shown here, and it enters based on the expression on the lymphocyte of a chemokine receptor called chemokine receptor 7, or CCR7. And then the S1P1 receptor present on the cells will enable the cell to eventually egress or leave the lymphoid back into the circulation based on a gradient of S1P, the ligand that attracts the cell out of the efferent lymphatic and back into the circulation. Now, what happens when you introduce the S1P receptor modulators, and again through the effect on S1P1 in particular, is that you get downregulation of the S1P1 receptor, and it fails to upregulate on the surface of the cell, which means the cell will no longer see the gradient of S1P and essentially gets trapped and sequestered within the lymphoid tissue. So cells expressing CCR7 will be preferentially trapped within the circulations, and ones that don't will continue to circulate. This slide indicates the specificity of the approved as well as emerging S1P receptor modulators, and in a cartoon fashion shows from left to right the fingolimod, siponimod, ozanimod, and ponesimod binding predilections. And you can see that for fingolimod, which is relatively less selective, there is binding to all but S1P2, to which none of the other agents bind. And then you see more selectivity with siponimod, ozanimod, and ponesimod, where for siponimod and ozanimod, the predilection is for S1P1 and 5, and for ponesimod, almost entirely S1P1. What about effects of these agents on lymphocyte subsets? Showing here as an example the fingolimod dataset from the Fluent study. And the Fluent study looked at two cohorts of patients. They were either naive or already treated. And the cartoon here shows you the effect of fingolimod on these two patient cohorts. And what you'll see highlighted in red are the impact on different immune cell subsets, particularly subsets of T cells for the purpose of this discussion. And the vertical line indicates no movement of cells, and you can see that most of the cell subsets remain unchanged in patients who continue fingolimod after having been on it for some time, whereas the fingolimod naive are somewhat shifted to the left, some more than others. And the main message is that there is a differential impact on different immune cell subsets with a greater impact and reduced, particularly reduced proportions and numbers of naive CD4 and CD8 T cells and central memory CD4 and CD8 cells with a lesser impact on the effector memory subsets of both CD4 and CD8 T cells. And this has been seen, as shown here in this slide, for ozanimod and for siponimod, essentially as a class effect. What about adverse events associated with these agents? Well, with fingolimod and attributed to the potential off-target modulation of S1P receptors for this less selective agent, one identifies across the top the cardiac, and then in the middle eye-related phenomena and pulmonary. And indeed, there's a contraindication in individuals with a range of recent cardiac or cardiovascular experiences. And hypertension also is something that one needs to think about in the context of the fingolimod initiation and follow-up. And these, again, are thought to be potentially related to off-target effects through S1P2, S1P3, with S1P3, as I'd mentioned, likely to be the most responsible for some of the cardiac effects. With respect to the eye, there's been an issue with macular edema, not a major issue, but one that we're aware of, and may be related to S1P1-mediated effects, although the S1P2 may also be involved in some aspects of an impact on eye, studies in animals not really emerging as an issue with humans. And finally, the pulmonary system, there's been some concern in small numbers of patients with relation to FEV1 and DLCO or diffusion capacities. And this again is thought to be partly, at least in terms of the S1P2 and S1P3. So this slide again makes the point that with lesser selectivity towards the S1P receptors, there may be a broader range of off-target effects in different organs. PK and PD considerations may also be relevant and have implications for clinical care. And this busy table shows you the different S1P receptor modulators on the left, and then across the top and in the different columns, different metrics that are pharmacokinetic or pharmacodynamic. And I'll just make the point here, focusing initially on the time to maximal concentration. You'll see that siponimod reaches that fairly quickly, within 4 hours, ozanimod also within a number of hours. Greater duration to reach max concentration with fingolimod, and quite short in the context of ponesimod, 2.5 to 5 hours. This is something that can be thought of also in terms of half-life or T-half elimination, which you can see here differs across the different agents, with the shortest T1 half attributed to siponimod and ponesimod in the order of 25 to 30 hours, with ozanimod being ranging depending on the metabolite consideration, and its metabolite, the CC112273, has a longer T-half elimination, and fingolimod about a week or so for its half-life. This manifests in different impacts on the pharmacodynamics, as observed here in terms of decreasing lymphocytes, both the median decrease in the maximum count as well as the ultimate maximum decrease in a steady state, again showing a range of effects across the different molecules that are a reflection of these pharmacokinetic considerations. And an important point with respect to this class of drug, which in general would be viewed as a reversible type of therapy as opposed to a depleter. It doesn't actually kill the cells, they're sequestered, and when the drug comes out of the system, the cells come back into the circulation, although what you'll appreciate here is that the reconstitution kinetic appears to be quickest for ponesimod and then for siponimod, followed by approximately a month for ozanimod and 1 to 2 months for fingolimod, the less selective agent. We're now moving on to a few slides that summarize efficacy insights from the phase 3 pivotal trials, looking here at fingolimod and its relapsing remitting MS program from Freedoms 1 and Freedoms 2 and then Transforms, where the Freedoms program was looking at fingolimod versus placebo and the Transforms was looking at fingolimod versus the once-weekly interferon beta 1A. And you'll appreciate, as you look at the bottom, I won't go through all the detail, is that there's at least a moderate impact on annualized relapse rate, the primary outcome measure of these studies, approximately 50% reduction, a very handsome reduction of the development of new brain MRI lesions, and when compared to placebo also an impact of 30% reduction in 3-month confirmed disability progression in this cohort of relapsing remitting MS patients. In ozanimod, we're looking at 2 large trials of patients with relapsing forms of MS, over 1,000, 1,300 plus in each of these Sunbeam and Radiance studies. And they were looking at a comparator with interferon beta 1A again. And you'll see here 2 doses of ozanimod in each of these studies, 0.5 and 1.0 milligrams. And again, with the active comparator here, annualized relapse rate reductions which are at least in the moderate efficacy range, and decent impact on the development of new lesions as measured by MRI. Siponimod was studied in a single large trial of patients with secondary progressive MS. It was a well-designed and large study in pretty representative population of patients. You can see here that the entry criteria included a range of EDSS of 3 to 6.5. This was a randomized placebo-controlled study, and the treatment was up to 3 years. It was really an event-driven study, so an elegant design. And here, the primary outcome measure shown at the bottom, the 3-month confirmed disability progression, was successfully met with a 21% decrease in the risk versus placebo, and also an important impact on any aspects of relapsing biology, including, again, over 50% annualized relapse rate reduction compared to placebo, and a very impressive impact also, as per the class of agents, on the development of new brain lesions. Ponesimod studied to this point in a phase 3 trial in patients with relapsing MS. This again is a sizable study, over 1,100 patients, a broader EDSS range, and looking at ponesimod with the active comparator of teriflunomide 14 milligrams daily, showing as the primary outcome measure significant impact on annualized relapse rate reduction of a little over 30%, and also hitting endpoints related to the development of new brain lesions, as well as reduced fatigue and a favorable impact on brain volume, with more patients achieving a no emergence of disease activity, or NIDA 3 metric as well, compared to the teriflunomide. So practical aspects for consideration and some contraindications as per the label other than hypersensitivity are shown here. Several are shared across fingolimod, siponimod, and ozanimod, and these include the considerations at least of current or prior cardiovascular history. In the case of fingolimod, there are some additional label-related details that relate to particularly cardiac rhythm-related issues. And in the context of ozanimod and related to the metabolite, although these haven't emerged as major issues, there's the consideration around severe untreated sleep apnea and concomitant use of MAO inhibitors. In terms of the safety summary, and based again on prescribing information in the labels, these drugs are generally well tolerated and overall quite safe. There are nonetheless some precautions that we want to be aware of, and I won't go through all the detail here, except that all of them share certain considerations that relate to just making sure and monitoring for infection, liver injury, increased BP, respiratory effects as noted, the siponimod and ozanimod and then fingolimod in different ways with relation to the cardiac considerations we'd noted, and fingolimod, which one notes, of course, has had a considerably longer duration of exposure and number of people exposed, clearly has PML emerge in a very low frequency of patients, but can happen as monotherapy on this agent, and one continues to monitor, and we've learned a lot about how to risk mitigate in the context of this class of agents. Additional common but not particularly serious adverse events have been noted here in terms of small levels of transaminase bumps, headaches, some GI symptomatology, and again, some differences in what were reported across the trials, but a little difficult to compare, not only because the trial populations are different, but also because the exact approach to measuring and ascertaining adverse events is not identical across trials. Monitoring and titration. This slide highlights some of the assessments that are important to do prior to initiation of this class of therapy, shown there on the left, and then in terms of the first dose monitoring versus titration of medications, the experience over time has had the siponimod and ozanimod trials do a dose titration, which has identified no longer needing to do a first dose monitoring, which is something that is still present for fingolimod and small subsets of patients with siponimod. So to summarize, the S1P receptor modulators all as a class effect reduce circulating lymphocytes. This is a selective effect on different types of lymphocytes common across the different agents and reflecting an action in particular through the S1P1 receptor. The specificity and the PK/PD differences between these molecules may contribute to some differences of clinical relevance amongst these different agents. Not so much on the efficacy, perhaps more so on the safety side. And again, in the absence of direct head-to-head studies, this is of course difficult to firmly or formally comment on. The higher degree of S1P1 specificity or S1P1 and S1P5 selectivity may limit off-target effects, and modulators in this class are effective at reducing relapse rates and decreasing substantially the development of new MRI lesions in patients with relapsing forms of MS, and as noted with siponimod in the SPMS trial, also a positive study there. So here I'll turn to our first practicum. We'll describe a case study, and then I'll ask my colleague and chair, Professor Cree, to comment. So Corinne is a newly diagnosed 34-year-old woman. She happens to be the owner of a gourmet food cafe and store. She has a relatively recent diagnosis of MS in the last year, although initially was not particularly excited about the prospect of going on any immune therapies. She wants to continue to run her business, lead an entirely normal life. She has an EDSS of 3 on the basis of some bowel, brain fog, and particularly hand numbness, and has had now an attack in the last month, presents again, and seen on MRI to have 2 gadolinium-enhancing lesions, 3 T2 lesions, and is asking now, in discussion with you, what you may do therapeutically. So, Bruce, how would you approach this situation?
Well, this is a patient who is newly diagnosed and has already developed some degree of residual disability. Her EDSS score is 3. She's had a high attack frequency over a relatively short period of time, although we don't know exactly when her diagnosis occurred. She's had 2 or 3 attacks, and she's got contrast-enhancing lesions on her MRI. And she's a small business owner, and she wants to be able to continue running her business. And I think the thing that catches my mind here in this case is the brain fog and memory disturbance that the patient is relaying quite early on in the course of the disease. So to begin with, I think we have to think about when her last attack occurred, and have we treated that attack, or we used corticosteroids for treatment. But in general, we have to be thinking about what types of therapy this patient might be treated with. We would want to think about highly effective therapies, I think. At least that would be my inclination. But the patient potentially could be treated with other treatments as well with good efficacy.
Yeah, I think, and I share your thoughts in terms of this patient having active disease clearly should be on a therapy. One would certainly want to understand what her reluctance might have been previously and help her with this important decision, and that it could be a broad range of therapies. One would probably aim for something that's at least of a moderate efficacy and something that she will tolerate well in terms of her lifestyle. Bruce, what role might you think that S1P receptor modulators in particular may play in her care?
Well, certainly you can think about S1P receptor modulators, and I would, in addition to other disease-modifying therapies. When I think about DMTs, I really think about them coming together more or less in three classes of medications, those that I think as being modestly effective, which are older self-injected medications. I also tend to bundle teriflunomide in that group with about a 30% reduction overall in relapse rates with those medications. The next tier of therapies, I think about the S1P receptor modulators, such as fingolimod and ozanimod and siponimod, as well as dimethyl fumarate and diroximel fumarate. And then I think of the high efficacy therapies, which really are the anti-CD20 monoclonal antibodies and natalizumab, among others that have more side effects. So I think about each of these classes of medications. Each poses particular risks and benefits for the patient. I would present each class of drugs to the patient and then see what she might want to do. This particular patient might want the convenience of a once-daily oral disease-modifying therapy. And I think there you've got S1P receptor modulators to consider. The nice thing about these drugs is their ease of use. They are administered once a day. They are generally very well tolerated. There is some screening that has to be done before initiation of these treatments. But the screening really is not too bad. There's minimal monitoring after initiation of treatment. And generally speaking, these are quite safe, well-tolerated medications that can be effective over the long term. So I do like this class of medications to be considered among others for this patient.
And would you comment on the newer S1P receptor modulators, the more selective ones, and considerations in her particular case?
Well, sure. So the newer agents appear, at least at face value, although this is using cross-trial comparison, of course, to be perhaps a little bit better in terms of side effects compared to the older agents. So looking at, for example, ozanimod and comparing that to fingolimod, one of the things that stands out when you look at the prescribing information is the need for a first dose observation. And this patient who doesn't appear to have cardiovascular risk factors and very likely would have a normal EKG could potentially go through and initiate treatment with ozanimod without the need for a first dose observation. And so that would be less interruption for her daily routine as she's a small business owner.
Right. And I think that the other dimension for which we're sort of looking to see more compelling data, but is intriguing, is that the selectivity to S1P1 and 5, and in fact the preservation of some effect through S1P5 may have, for the neurogeneration, ozanimod and siponimod, an impact on the CNS. And there's interest in whether that could favorably impact CNS compartmentalized inflammation. Whether or not that's relevant to someone like this in terms of brain fog and memory issues, I think remains to be determined, but is of interest for us to consider as well. And so in terms of current guidelines and guidance on the DMTs, and this is from the MS Coalition, I think we would certainly agree that this individual warrants having a discussion about initiating an FDA-approved therapy as soon as possible for the diagnosis of active relapsing remitting MS, and one would consider at least a moderate, if not high efficacy therapy as a reasonable one to try to limit and stop any development of new disease and further disability progression, physical and cognitive. And of course, this done very much as an active decision-making process that is shared with the patient and those close to the patient.
And I would just say that's an extremely important point, Amit, that you just made, which is the shared decision-making. You or I might think, well, a particular drug would be just the ideal drug for this patient. But at the end of the day, if we prescribe that drug and it either sits on the shelf or in the refrigerator and is never used by the patient, then we really haven't done the patient proper justice. So what I like to do in my personal practice is to separate a discussion of disease-modifying therapy after discussion of the patient's diagnosis. So really, you're looking at another appointment with the patient where we can really dig down into the side effects and efficacy of each drug, and I really try to suss out what that patient might want for themselves, what their expectations of therapy should be, and try to match the drug with the patient as best as possible.
That's an excellent point, Bruce. We do the same. We split the initial new MS diagnosis into at least 2 sessions, just as you describe. A common question that comes up, whether by the patient or someone close to the patient, is what about the long term? And I wonder if you can just comment, and in particular in relation to the S1P receptor modulators, what do we know about long-term efficacy and safety of these agents?
Well, they do tend to be quite safe over the long term. Most of the adverse events that we see occur within the first year of treatment, although it's true that one can occasionally see adverse events of interest, such as macular edema, occurring years after use, although that is really quite uncommon. Most of the time when we see liver function abnormalities elevate, that occurs, for example, in fingolimod within the first year of treatment. And so as patients go beyond that initial period of time of treatment, they tend to tolerate the medications remarkably well. The drugs don't lose efficacy over time, and I think that's another concern that many patients have. If they start a more effective treatment, are these more effective treatments going to lose their benefit over time? Should we be reserving the more effective treatments for later on in the course of the disease, as it used to be our dominant philosophy? It wasn't that long ago that we would really adopt that type of approach, where we would start patients on a modestly effective treatment and reserve the more effective therapies for later on in the course of the disease. I think our thinking here has really changed and evolved over time, and now in general we are much more willing to begin more effective therapies early on, knowing that they don't lose their efficacy over the long term.
Thanks, Bruce. That's excellent commentary. We have another case study here of Marta, who represents someone who's had continued attacks despite treatment. Marta is a 34-year-old Latina woman. She works in HR for a public school district, was diagnosed with MS a couple of years ago. Her EDSS at this point, 2 years after diagnosis, is 4.5, and she sometimes needs a cane to walk safely because of an impaired sense of touch in hands, and difficulty with ambulation, tremors, visual field loss, and also comments about slowed thinking. She has 12 lesions on her MRI and now presents with 5 that are gadolinium enhancing. She was historically started on interferon beta 1A at diagnosis. She then had 2 attacks, and again, the recent MRI changes, as noted, indicating disease activity, suboptimal response to the interferon. And she confesses to having missed and skipped some interferon, which of course is an important question in terms of concluding that there may be a suboptimal response, but it's clear that this is something that is hard for her to stick to. She doesn't really like it. She doesn't always remember. And the question now is, what might you do? How might you approach this situation?
Yeah, I think we do see patients a lot like this fairly frequently in clinical practice, and it is very challenging for patients to take self-injected medications that have side effects over the long term. Some people do well with these medications, and I think we probably both have quite a few patients in our practice who are still taking interferons or glutamate acetate. But this patient clearly is having a hard time keeping up with injections. So here I think it makes a lot of sense to offer this patient different treatment options, including oral options as well as high efficacy infused treatments. So here I'm quite worried that this patient is slipping toward or moving towards secondary progressive MS. Their EDSS score is quite high. It's not clear to me whether that represents recent relapsing disease activity, but she certainly has 5 GAD-enhancing lesions on MRI. So this is breakthrough disease or a lack of adherence with very active MS. So consideration of a high-potency therapy would be reasonable here. and I would include S1P receptors in that, receptor modulators in that discussion with the patient.
Great, thank you very much, Bruce. So in terms of, again, another input from the Multiple Sclerosis Coalition, here in the context of switch, one certainly would consider a high efficacy DMT in the context of this breakthrough disease. And I think what was noted already is that breakthrough represents what happens when someone is on an agent or prescribed an agent, and it's not sufficient to keep his or her disease under control. And one needs to consider that as either a setting where the breakthrough disease is occurring when someone is fully on the medicine, or simply not able to take that medicine, and again would be absolutely warranting a treatment switch discussion. One would consider the tolerability, of course, and safety considerations as the other important dimensions of entering a switch conversation. And we want to make sure that DMT changes are done for what is identified here as medically appropriate reasons. I think this is just to make sure that people are not too hasty or glib about changing. And sometimes it's a question of understanding how to work with people to be able to take a given medicine more consistently to have good control of their disease, but also not to impose something on patients without really understanding what's going on and being sensitive to reasons why they may not be as interested or keen to continue with an agent, even if we're not immediately sensitive or aware of it. And of course, our new approach to the new MS, if you like, is proactive clinical and MRI monitoring for any activity that may emerge subclinically above and beyond what a patient may report or what we may capture on exam to trigger discussion of an alternative regimen, and again emphasizing through and through the shared paradigm of decision-making with the patient. And so improvements following switch from injectable DMT to S1P receptor modulators have been identified, particularly in clinical trial extensions, and these include reductions in lesion number, significantly lower annualized relapse rate, particularly of severe relapses, a lower impact of relapses on activities of daily living, again representing or reflecting less severe relapses, a smaller reduction in brain volume and significantly improved quality of life and patient-reported outcomes, as well as over time, as Bruce has already alluded to, a lower adverse event rate as some of the earlier experiences with therapies, any therapies, may dissipate. There may be tachyphylaxis and so on. Bruce, I see we have some questions here from the audience, and I might pose one or two to you. In fact, one that you've commented on already is the long-term safety of S1P receptor modulators. The other that I'll ask you to comment on is what education might you provide patients when starting, in particular, an S1P receptor modulator?
Great. Both questions are excellent questions. And so I'm going to take the long-term safety question of S1P receptor modulators first. So the best long-term data we really have for S1P receptor modulators comes from the fingolimod experience. And generally speaking, most of the adverse events associated with fingolimod were identified during the context of the clinical trials. However, some long-term events of special interest did emerge. And after several years of post-marketing experience with fingolimod, we found the first case of progressive multifocal leukoencephalopathy, PML, a lethal brain virus infection, occurred in a fingolimod-treated patient. We've now seen several other patients who were on fingolimod monotherapy develop PML. This is a rare but very serious adverse event, an opportunistic infection initially identified in MS patients in the setting of treatment with a different medication, natalizumab. So this is rare. It occurs at a rate of about 1 in 10,000 approximately. It does seem to be exposure related, so the patients on treatment for longer periods of time do seem to have a higher risk. There seems to be age as another risk factor, although that's not entirely clear. So this is one of the things that we need to educate patients about. And with respect to the newer therapies, siponimod and ozanimod, that have not been on market for particularly long, I think given this possible class effect, we have to educate our patients to the possibility of this serious adverse event when initiating these other treatments as well. In regard to other adverse events, other opportunistic infections include cryptococcal meningitis or other cryptococcal infections. They've been reported with fingolimod and in at least one case with siponimod. So again, it makes sense to be aware of these opportunistic infections. I think they're likely going to be class effects, but we haven't seen them yet with ozanimod, and of course, this medication has not been in the post-marketing experience very long. In terms of education, the second question here, I think it's very important as part of this shared decision-making to educate patients about the drugs they're going to start as much as possible. Patient brochures, I always hand patients the FDA-approved brochures. I ask patients to read through it to make sure that they understand. Additional excellent resources of information for patients come from the National Multiple Sclerosis Society's website. And patients generally are encouraged to stay up to date as much as possible. And this means also attending patient-oriented seminars so that they can learn about the treatments that they're currently on or what other treatment options might be available.
Thanks, Bruce. Excellent insights. And so I'll pass the baton on to you for the Masterclass 2, in which you'll be talking about examining the potential effects of S1P receptor modulators on brain atrophy metrics in patients with MS. Bruce, please.
Thank you very much, Amin. So when we think about multiple sclerosis, we have to think about end organ damage that's occurring in the brain. And what this slide shows is progressive loss of brain tissue. This is the same patient who's had serial MRI scans performed over a 10-year period of time. And you can see that initially the brain volume starts off as normal, and gradually over time you can see the ventricles dilate, the sulci increase in size, and you can see also evolution of T1 black holes on this MRI scan. And what we're really trying to do with early intervention and treatment in multiple sclerosis is prevent this end organ tissue injury. Not surprisingly, since the brain is doing most of the thinking in our body, when you lose brain tissue, not surprisingly, you're losing cognitive capacity as well. And cognitive injury is one of the major reasons for disability in multiple sclerosis in association with ambulatory impairment and fatigue. The spinal cord is also involved. We know that spinal cord atrophy occurs in multiple sclerosis, and there's a greater degree of spinal cord volume loss that occurs in patients with progressive MS or in patients who are more disabled. And what this slide shows is that gray matter volume loss in the spinal cord correlates very strongly with the EDSS score. And this is work done in our group. We found both cervical gray matter atrophy, thoracic gray matter atrophy, and brain gray matter atrophy, all contributing to disability worsening in MS. So there is an association of deep gray matter and thalamic volume loss with disability progression in multiple sclerosis. Longitudinal study here in relapsing MS and secondary progressive MS found that thalamic and striatal volumes were associated with EDSS at baseline. So the smaller the volume, the higher the EDSS score. Thalamic volume loss, however, was associated with change in EDSS score at follow-up. So MS phenotype and annual rates of brain volume loss to some extent predict worsening disability. Now, there's a recent consensus statement from the Magnum's group recommending atrophy measures and how they could be implemented in clinical practice. Now, at this point, use of atrophy measures in clinical practice is really quite limited. This remains a research tool. This is due to a number of factors, including the fact that many patients are scanned on different scanners at different periods of time. Different field strengths with each scanner are sometimes used, as well as different imaging protocols. And so we still do not have a standardized MS scan that could be conducted at multiple sites using the same pulse sequences. And this is a major limitation to implementing precise measurements of brain atrophy over time. Nonetheless, this is something we would like to be able to do. Work done in our group and many others are trying to come up with ways to standardize assessments using a variety of MRI platforms and maintenance of a similar or identical pulse sequence. Even with all of those factors in place, it still requires additional post-processing time that can be quite labor intensive. And so we do have a bit further work to do before we are able to operationalize these measures in clinical practice. One of the things we do when we're monitoring patients and assessing how well a patient might be doing is looking at different metrics of disease activity and progression. The NEDA 3 metric looks at evidence of no relapses, no disability worsening, and no evidence of MRI disease activity. Adding to that is the NEDA 4 metric, which includes no loss of brain volume within a certain parameter. And now with NEDA 5, also looking at biomarkers for inflammation and axonal loss. As you start to add more and more of these parameters, you find that there are fewer and fewer patients who are achieving true remission of all disease activity as can possibly be measured. I think, for real-world practical application, some of these techniques are still a little further away. It's not quite so easy to measure markers of axonal damage, although this is getting easier and easier over time. So we used to think of inflammation and neurodegeneration in multiple sclerosis as being a two-tiered process, where inflammatory injury that would occur early in the course of the disease would predispose to a neurodegenerative aspect later in the course of the disease. Recent work is showing that these two processes are intertwined and that there's evidence of progressive worsening early on in patients who are still considered to have relapsing multiple sclerosis. There's also brain volume loss that's occurring right at disease onset. So we know that there is focal inflammatory disease activity that's contributing to multiple sclerosis disability, but in addition to that, there is more diffuse tissue injury occurring as well, most likely at the microscopic level beyond the ability of the MRI scan to adequately assess. When we think about brain volume loss, we have to think about ways of slowing brain volume loss over time. Fingolimod had excellent data from pooled phase 3 clinical trials showing an impact of fingolimod on the overall brain volume loss, on deep gray matter volume loss, and on thalamic volume loss as well. Cortical gray matter was not influenced in these studies. This may be due to the fact that these trials were conducted using older scanning technology, and perhaps more recent work would show a different effect. But nonetheless, we do see an overall beneficial effect of fingolimod. And what I find quite interestingly in these studies is no evidence of pseudoatrophy. Ponesimod also presented data recently showing an impact of ponesimod on brain volume loss in comparison to teriflunomide. This was interesting to me because teriflunomide itself is proven to have an effect on slowing brain volume loss. So the effect you see here with ponesimod is beyond that of what was observed for teriflunomide. I think this is a fairly robust effect and speaks well to preservation of tissue, brain tissue with use of ponesimod. In the ozanimod clinical trials, whole brain volume, cortical gray matter volume, and thalamic volume were preserved over both a 12-month period of time and a 24-month period of time with ozanimod compared to interferon beta-1a. So like fingolimod and ponesimod and data from siponimod, ozanimod prevents loss of brain tissue over time. And I think this is one of the major advantages of these therapies over the older disease-modifying treatments, the interferons, glutamate acetate, and at least with respect to ponesimod, teriflunomide as well. We see more robust effects on preservation of brain tissue with these S1P receptor modulators. So to summarize, brain volume loss, including gray matter and thalamic volume loss, are associated with disease progression and disability in multiple sclerosis. Treatments that minimize brain volume loss and atrophy, in my opinion, should be started early in MS treatment management, and evidence indicates that S1P receptor modulators reduce brain volume loss. So we'll move on to another case. And this case is of Marcus, a patient who has aggressive MS. This is a 45-year-old African-American man. He works as a professional writer. He was diagnosed with MS at the age of 40, but over this 5-year period of time, he has already evolved to require a cane to ambulate. His EDSS score is 6. He has difficulty with walking, left arm numbness. He has difficulty with urination, difficulty with speaking. His MRI shows multiple lesions, and it's noted for a decrease in brain volume. He was started on natalizumab, but he notes that the treatment has not been very effective, not so much in terms of relapses, but he describes himself as gradually slipping over time. He also notes that the recent coronavirus pandemic has made it more difficult for him to get treatment, and this is a concern that many patients have when going to infusion centers. He's very worried about brain volume loss and possibly using another injectable medication. So things to consider here. What role might S1P receptor modulators play in his care? What are the considerations in the COVID-19 era? I think we're going to come back to that topic. And what role would S1P receptor modulators have in slowing brain volume loss for this patient? Amit, your thoughts?
Thanks, Bruce. So this is an individual, as you pointed out, one would be concerned about in the sense that there's been fairly substantial deficits accumulate over a relatively short period of time. This is a person, an African American, and we know that MS can manifest more severely on the average in these individuals, and one wants to make sure that the therapy that's on board is as able to limit all aspects of disease as possible. Natalizumab, of course, is a high efficacy therapy for relapses, and one certainly wonders whether not doing well and getting worse in the context of a treatment like natalizumab reflects some of the non-relapse progressive biology emerging, given the expectation that natalizumab should be quite effective, with the exception of the scenario where there may be anti-natalizumab antibodies developing that could, of course, limit its effect. And as noted, the particular concern over brain volume decreases. The S1P receptor modulators, in my mind, could play a role here in terms of a switch. One might say that, of course, without head-to-head data, but the impression that they may be high efficacy, but perhaps not quite as high as natalizumab on relapses. But people are different, and I think the earlier comment made about different modes of action of therapies is important, and there may be one therapy of high efficacy that a person will not respond to as well as another therapy of even moderate efficacy, because we're talking about averages of clinical trials, but people are different. And in particular, with brain volume being involved in this individual in an important way, and given what you just described in terms of S1P receptor modulation, perhaps through the potential to get into the CNS and impact not just the relapsing biology, that this would certainly be a class to consider.
So what do you think about the siponimod data? This was a clinical trial that was done in secondary progressive multiple sclerosis, as you mentioned earlier, Amit.
Yeah, I think that the siponimod, one of the two selective S1P1, S1P5, this, as I'd mentioned, was a very good study in my mind in terms of a representative patient population with SPMS, and it clearly hit the primary endpoint of limiting disability progression and multiple other measures, including those that we commonly think of as reflecting an impact on relapse biology. And an important question in the study had been, since, as you also noted, inflammation, including focal inflammation that we think of as relapse biology, continues even when individuals have what we clinically have now referred to as secondary progressive MS. An important question from this trial was how much of the impact on the outcomes is because of limiting relapse-related disease activity, including relapse-related progression of disability, versus impacting the true progressive biology, if you like, the non-relapsing biology. And certainly the pre-planned subgroup analyses and additional analyses suggest that while an important contribution to the outcomes may reflect impacting relapse biology, that there does seem to be an additional layer that is not readily explained by impacting relapse biology, and it's attractive to think of it as possibly impacting non-relapsing progressive disease.
That's great. So there are multiple factors associated with aggressive multiple sclerosis, certainly demographic factors. As you mentioned, this patient's African American, and there's data to suggest that African American patients might have a more aggressive disease course. Relapse severity and relapse frequency, the numbers of relapses that occur early on in the course of the disease, and the accrual of disability with the superimposed relapses. All of these are clinical features associated with more aggressive MS. Radiographic features, of course, include high T2 burden of disease, multiple GAD-enhancing lesions, and loss of brain tissue. And I would say that loss of spinal cord tissue now, very important factor to think about as well. So when you think about our African American patients, often they have more frequent relapses. There's a faster transition from relapsing MS to secondary progressive MS. And data from the NARCOMS registry indicated that African Americans are more likely to have severe disability than their white counterparts. You can see here a distribution of African American and white patients with MS across the EDSS grades, as well as benign and malignant categories. And generally, you get the impression of a greater burden of disease in African Americans. So prevention of brain volume loss is important, and it's important not only for our considerations, but it turns out to be very important for our patients as well. When asked about what the relative importance of various attributes of disease-modifying therapies, patients reported rate of brain volume loss as being extremely important. Right at the top of the list here, in terms of treatment attributes that would be desirable. So patients are concerned about losing brain tissue, and I think very reasonably so. The brain is our most vital organ, and who wants to lose brain tissue more rapidly from an underlying disease state when there's something that we can do about it? So we just have a question from the audience. What is the evidence for S1P receptor modulator effects on improving cognitive function in MS? Amit, do you want to take that one?
Sure. So we do have evidence. We have evidence both from the siponimod and the ozanimod trial programs with respect to the impact relative to the comparators of the S1P receptor modulators on limiting the decline in cognitive function as assessed with the electronic SDMT, the single-digit modality testing, which in some ways captures cognitive processing speed and is something that has been shown to have sort of face validity as well as emerged in clinical trial programs of MS as a pretty good way of capturing clinically relevant aspects of people's cognitive function.
Excellent. And so there's also another question from the audience. How often and in what circumstances do you typically consider using an S1P receptor modulator as a frontline therapy?
So we're quite comfortable using S1P receptors, having that as part of the conversation as a first-line agent. I think that overall, the knowledge that we have to date has enabled us to risk stratify, do some screening testing that would preclude the rare individual who shouldn't be on this type of agent. And this is something that people, generally speaking, will tolerate very well, will be happy with in terms of the relative absence of annoying side effects. And as a once-a-day pill for many individuals is a very good solution for their MS. And with moderate to high efficacy profile, this is something that would be attractive to many individuals, so we are quite comfortable thinking of it as first line or, as we've already discussed, as a switch option in a variety of cases.
Wonderful. Thank you. So I now want to turn attention to a topic that is very important for consideration for many of our patients, which is the COVID-19 pandemic. And many patients want to know whether they're at increased risk for coronavirus infection. Many patients want to know whether the disease-modifying therapies they take are making them more susceptible to severe complications of coronavirus infection. And so this, of course, is an extremely important topic. A couple studies have been published. The first one here, which is a registry coming out of the Italian experience. And here, overall, I think the take-home from this registry was that although many patients were on treatment, relatively few patients succumbed and died from coronavirus. There were a few people who did die. Of those, we didn't see a clear association with disease-modifying therapies. Another study from the French experience looked at the overall impact of coronavirus in MS patients. And this study found that untreated patients were at higher risk for complications of coronavirus infection, but that when looking at the overall rates of mortality, again, these rates for MS patients overall were quite low. There was a higher risk of severe outcomes associated with greater disability, with progressive MS, with age and other recognized comorbidities. Within the disease-modifying therapies, the rates of severe coronavirus infections were grouped by disease-modifying therapy class and were lowest with the interferons and with glutamate acetate, somewhat higher with teriflunomide, dimethylfumarate, and natalizumab, among others, and were perhaps highest with the alemtuzumab, cladribine, ocrelizumab, rituximab, and fingolimod group. So this raised some concern as to whether some of these high-potency disease-modifying therapies might be associated with worse outcomes. Additional recent observations that were presented at a meeting but have yet to go through peer review and the publication process suggest that anti-CD20 monoclonal antibodies might be associated with worse outcomes. Amit, as a B-cell biologist, what's your take on all of this data? Do we think we should be stopping treatment or counseling patients differently about use of disease-modifying therapies in the setting of this pandemic?
Well, Bruce, I think you highlighted the importance of these questions in terms of our community. And of course, at the beginning of the pandemic, we were extremely concerned about many patients treated with drugs that impact their immune system in the face of an evolving pandemic. We've learned a lot, and I think overall what we've learned has been reassuring. We've learned that people who have MS don't have increased risk of either becoming symptomatic with the virus, the SARS-CoV-2 virus, nor of the severe complications just by virtue of having MS, which would be a first-pass question of importance. And the other is that we've also learned more about the biological underpinnings, if you like, of the severe COVID complications, which is what really concerns us. And it turns out that our current understanding indicates it's not the virus that's running rampant that's causing these severe complications that might get you into the intensive care unit on a ventilator and with a risk of death. Rather, it's the person's own responses, particularly their own immune responses to the virus, that cause these complications. And in fact, several of the MS therapies have been now looked at, and other classes of immune targeting therapies have been looked at as a way of trying to mitigate, limit, or stop, if possible, the development of the serious complications. And there's been some positive experience with a few agents, including ones used in the MS world, proving to be beneficial in that regard. Anti-CD20 in particular, I think, as you point out, we need to see this data. It needs to mature and get through peer review for us to understand the context. One has to be a little careful, I would say, in that in different populations, there may be different profiles of patients who are initiated on different types of treatments. And as a high efficacy therapy, there may be a population in which anti-CD20s were introduced in patients who are more severely affected by MS, have greater disability, may on the average be older with additional comorbidities. And each one of those factors, as you note already, are associated independently with an increased risk of severe COVID complications. So how much of those results are attributable to the anti-CD20 or not is an important question, but I think remains to be seen.
Thank you, Professor Baror, for that excellent summary of our current understanding of coronavirus and its implications for multiple sclerosis.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.